Hey listeners, it's Lindsay Smith-Rogers with some exciting news and an ask for you. The Public Health On Call podcast is coming up on 1,000 episodes. And to mark this milestone, Josh Sharfstein, Stephanie Desmond, and I are answering your questions about the show. Have you ever wanted to know how we pick topics or how our hosts prepare for interviews? Now's your opportunity to ask your question and hear your voice on the podcast. Send us your question as a voice memo to publichealthquestion@jhu.edu by October 31st. That's publichealthquestion@jhu.edu by October 31st. Thank you so much for listening, and we are excited to hear from you.
Welcome to Public Health On Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
It's Lindsay Smith-Rogers. Today, balancing the benefits and risks of acetaminophen, also known as Tylenol, during pregnancy. Dr. Angie Jelin is an obstetrician gynecologist and an expert in genetics and maternal-fetal medicine at the Johns Hopkins School of Medicine. She joins Dr. Josh Sharfstein to talk about how she thinks about the role of acetaminophen in treating fever and pain during pregnancy. Let's listen.
Dr. Angie Jelin, thank you so much for joining me today on Public Health On Call. How are you doing?
Great. Thank you so much for having me.
Could you start by introducing yourself to our audience? I understand you're an obstetrician.
I am. Yes, I trained at UCSF. I did both obstetrics, gynecology, and then I did a combined fellowship in MFM in genetics, which I think brings a little bit of extra expertise to the table in that when we do genetics, we think about all kinds of ways that different things affect the human body and development, not only genes, but teratogens and environment and all of those other factors.
Today, we're talking about advice during pregnancy, and that task has gotten a little bit more complicated lately. Would it be fair to say?
It has. I think it has evolved over the past many years, but certainly recent events have made some things more challenging.
So let's take the general advice. So before the events of the last few weeks, how do you approach taking medicines, for example, during pregnancy?
So we always are very cognizant of the idea that whatever we give somebody can affect the fetus. Of course, it's been studied for centuries as far as medications and toxins and teratogens, and some things are more clear than others, but we always try to limit the dose of anything that we give someone, but also with the idea that if the mother's not healthy, the fetus is not going to be healthy. So the disease, of course, in general, is often worse than the medicine.
That makes sense. And so you are trying to take into account both factors, the underlying condition and the risk that that poses to the mother and the baby, as well as the risk of medications to address the underlying condition.
Exactly. Everything we do is risk-benefit.
So let's shift to acetaminophen, which has been in the news lately because of the concern expressed by a number of our nation's health agency leaders that it could be associated with some adverse outcomes, including autism or attention deficit disorder in children several years later. Have you heard about those concerns over the years?
I think there's a lot of studies that show some associations between medications and different outcomes. And certainly there have been studies showing associations between acetaminophen and autism, but we have not determined causality.
In other words, you haven't reached a conclusion about whether acetaminophen is actually causing a problem like autism.
Yes, and I think that's the really important word is causation. There's a lot of associations that can be shown, but without randomized controlled trials, it's very hard to show that it's causative.
That leaves you in a position of considering the benefits versus the risks. You're in with a patient and you're going to say, we've got to make a decision. Let's talk about the benefits and the risks. Is that fair?
That's exactly right.
So let's talk about the benefits. When you think about acetaminophen use in pregnancy, what would be the potential benefits?
Right. So Tylenol is still a very effective medication for fever, particularly, but also for pain. We use it often for headaches in pregnancy, where it's very effective. And then also, of course, with fever, we're very concerned about the effects of fever on pregnancy.
Tell me more about that.
So there are a lot of studies that show an association, again, between fever and autism, but also fever and other congenital malformations and other problems that can be associated with the fever during pregnancy. So we do want to reduce the fever in pregnant patients.
And you mentioned pain. Is that also a concern for pregnancy?
We definitely want to reduce pain in pregnancy. There's also concern that if whatever's causing the mother pain could be causing the fetus pain, and the Tylenol could also be treating that.
And so part of your discussion with patients is, here's why you're concerned, and here would be the potential benefit of treating fever or pain in pregnancy.
Of course, every time we always think about what are the risks of not treating, what are the benefits of treating. If it's something short term, do we think it's not worth treating? But in general, with Tylenol being safe, we do usually recommend treating pain.
What about alternatives? I mean, what if a patient says, I'm wondering about Motrin, I'm wondering about aspirin. Do I have to use acetaminophen or Tylenol?
Right, because those are medications that in general, outside of pregnancy, we use pretty regularly. But those medications can cause a premature closure of the ductus arteriosus. So we generally try to avoid those in pregnancy.
That sounds not good, a premature closure of the ductus arteriosus. I remember some of that from my pediatric training. Could you explain a bit more what that means?
So in the fetal circulation, the ductus arteriosus directs the oxygenated blood into the fetal circulation. It's not necessary after we're born because we have oxygen from our lungs. But in the fetal world, the ductus is actually very important.
So we definitely don't want that closed. So those medicines are really off limits for people during pregnancy.
We use them very carefully for very specific situations.
Got it. Now let's talk about the risks. So how would you describe the risks to a patient of acetaminophen use in pregnancy?
Yeah. So, our societal guidelines really suggest that Tylenol is safe. There's a huge body of literature that over decades has accumulated where we have used Tylenol in pregnancy, and we don't see any congenital anomalies associated with Tylenol. And we really do feel that the risks are very minimal. So when we think about using it, we think about the indication for use and then the benefits of use. And one of the main indications we've been talking about is fever, which can be very dangerous in pregnancy.
And what if a patient brings in the newspaper and says, what am I supposed to do with these recent statements? How do you try to put that in context?
So I think it's important to, again, talk about association versus causality. And there are studies that have been published, including one out of Columbia, that shows that fever is associated with autism, and it actually also shows that people who took Tylenol to reduce the fever had a decreased risk of autism. So it does seem that it is probably the fever and not the Tylenol that is related to autism. Again, we cannot prove causality, but we also have a lot of data for patients who've taken Tylenol for other reasons that do not have children with autism. And of course, there is the study that's the sibling-controlled study that also shows that it's not related.
Sounds like you may have to have these kind of complicated conversations for a lot of different topics with your patient.
We do. For vaccines right now, it's a huge conversation.
How do you navigate these conversations when you may have guidance that is actually different from what people may be hearing on the news?
It can be really difficult. And I think that all we can really do is provide the information that we have available. I do think that societal guidelines and even institutional guidelines can support physician when they're counseling a patient to give them that evidence that this isn't just a personal choice. This is actually established based on national guidelines or institutional guidelines with a lot of data that's driven behind it. And so I often do tell them that the experts in the field who treat these patients and have studied this for their lifetime have these recommendations. And sometimes that can be helpful. There are certainly patients where the news is going to sway them over anything that I have to say. But as long as I have given them my expert opinion and the information that exists, I feel comfortable treating them.
Great. Anything else that you think is important for people to know?
One of the things I was thinking about when we talked about discussing this is just kind of the principles of teratogenicity and where we have come over the centuries, because we still use the principles that were established a long time ago, Wilson's 6 principles of teratogenicity. And I feel like it used to be that as obstetricians, we were gatekeepers to try to prevent medications to be given to patients that could cause fetal harm. And that was our main goal. And now it's often that we are trying to give medications to patients that other physicians don't want to give, but we weigh the maternal benefits in such a way that we still think that they're important medications. And I do think that Tylenol falls into that category where the risk associated with fever, not only to the mom, but the fetus, is pretty significant. And if we don't treat that, we could be doing harm.
In the past, you were telling people take medicines, but now you're helping them sort through the benefits and the risks, even if there's some people who are completely focused on the risks.
Exactly. There's a lot of medications that have a gradient where there could be some risk, there's benefit. And the question is, what is more important from a maternal standpoint? What is more important from a fetal standpoint? And then what is more important for the patient themselves? And how do they accept those risks and benefits?
Dr. Jelin, thank you so much for coming onto the podcast and explaining all that. It really helps.
All right. Thank you so much for having me.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Michael Bonfils, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production coordination by Catherine Ricardo. Analytics by Elisa Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.